I'm just going to make a few announcements that they've asked us to make as well. There is only one audience response question in here, but if you would like to answer that, just have your phones ready. You can scan the QR code at the beginning of the presentation or when the slide comes up. I just wanted to let everyone know that CME is available. You can start claiming CME on Wednesday, so tomorrow at noon. And please, other than us starting late, we would love for you to evaluate this session after the end. So you can either use that code or the code will show up on the slide when it comes up as well. I'm going to introduce our speakers who are now walking in. I'm so excited to see them.
Sorry, this lovely gentleman accosted us for not having badges.
I told the crowd. These are the people you came to hear, I know that, so it's like this would have been really awkward without them. Good morning. Good morning. All right, so I am really excited to have this distinguished panel here with us today. I did a lot of begging over the summer to get them here. They really are the experts in this area. I'm just going to go through the faculty, give you the introductions and their disclosures, and I'm going to give a little background, and then I'm going to turn it over to Dr. Uhueta, who is going to take us through a case to help us with our discussion. So our first speaker, after we go through the case, is going to be Dr. Behnood Bikdeli, who is an assistant professor of medicine at Harvard Medical School. You would think that would get him in without a badge, but apparently not. You can see he's an investigator in the thrombosis research group. I am really indebted to Behnood for his generosity in a lot of the scholarship that occurs in the area of pulmonary embolism. These are Behnood's disclosures. I've read through them carefully. None of these are related to anything we're going to be discussing today. Dr. Piazza needs no introduction either, but he is an associate professor of medicine at Harvard Medical School. He's the director of the section of vascular medicine. Again, someone who has been generous and allowed me to collaborate on multiple projects, one of which we are going to be discussing today. Those are Dr. Piazza's disclosures, again, not related to our talk today. My name is Lisa Moores. I am the Associate Dean for Assessment and a professor of medicine at the Uniformed Services University, which is the military medical school in Washington, D.C. My disclosure. And we're really lucky to have probably the biggest expert, right, the fellow. So we have Francisco Uhueta, who is a clinical fellow in Dr. Piazza and Dr. Behnood's institution, who is going to help walk us through a case to stimulate some of the discussion we want to share with you. These are our objectives. So just a little bit of background. I can tell by the number of people in the room. I'm excited that you're all here. I'm sure you'd agree that despite all of the advances we've had, that acute pulmonary embolism really remains, for many of us, a diagnostic and management challenge, particularly worldwide. And when you think about the fact that incidence rates are going up, probably due to the improved sensitivity of our diagnostic approaches, nonetheless, the mortality hasn't really changed, and I think there's a lot of room for us to continue to learn and understand the best way to manage these patients. Most of us, I think, use guidelines to help us in this decision-making, but it can get a little bit confusing because there are multiple guidelines and they don't always agree. And so when you're trying to make a decision, understanding where they agree, where there may be discrepancies, and particularly what might be behind those discrepancies can help you navigate. But we thought it would be important, I should say, Greg and his team thought it would be important for us to put everything together for those of us that manage patients with acute PE and to really outline in detail where these guidelines agree and where they may differ. In terms of the methodology, the guidelines that we focused on, we wanted to look at those that were from professional societies, looked at North America and Europe, and Importantly, if they were to be included in this compendium, they needed to have been based on a systematic review and had to employ some approach for evaluating the evidence. That could be grade, that could be another, but it had to be clear in the methods such that any of us could reproduce that if we so chose. And the study highlight areas that we wanted to look at, again, were where they agree, where they differ, and also importantly, where they're somewhat silent to help us understand where we need to do additional work. There are a lot of special populations that we think about in patients with acute PE. For this particular review, we chose to focus on those that are pregnant and those that have an active malignancy. So these are the guidelines that were ultimately included in the review. So we have the European Society of Cardiology guidelines, the Pulmonary Embolism Response Team Consortium guidelines, the most recent version of the CHEST guidelines, the 2011 AHA statement, the ASH guidelines, which are published in multiple different versions, but any of them that applied to the management, diagnosis or management of acute PE were included, and then finally the NICE guidelines. So I'm going to turn it over to Dr. Huerta, who is going to take us through the case.
Of course. So we're going to talk about a 66-year-old male. He has a past medical history of non-insulin dependent diabetes, obesity, and hyperlipidemia. This is a patient that has had left knee, total knee replacement previously, about a couple months, 4 or 5 months ago. But he comes in previously due to infected septic arthritis on that left knee. He had, a hardware removal, and now, current presentation, he comes in complaining of fever, altered mentation, shortness of breath, and chest pain. The vital signs on admission on his presentation is 102 degrees Fahrenheit, a heart rate of 116 beats per minute, and a blood pressure of 90 over 50 millimeters of mercury.
Morning, everyone, and again, apologies for the unintended delay. It's such a great pleasure and honor to be with you, and thank you so much, Dr. Morse, for the incredibly kind introduction. We've tried to intentionally keep the slides few so that there is ample time for discussion between us and also with your great contribution. Can't wait for it. The diagnostics that I want to quickly touch upon are really related to clinical decision-making for pretest probability, where D-dimer comes into play, and whether or not chest imaging to confirm pulmonary embolism has heterogeneity across these guidelines and across the subgroups of patients. And yes, empiric data from large registries shows that there's a lot of variation in terms of how we are using imaging modalities. Needless to say, CTPA has taken over for the most part, but believe it or not, that's not exactly what the guidelines say. So there is some variation across the subgroups, and I'm sorry that the slide doesn't come as clear as I would have hoped, but with CKD, pregnancy, et cetera, there is some variation. But let's fast forward to what these different guidelines say. And it's a busy slide, but I'll try to quickly walk you over this. For assessment of pretest probability, except for a couple of recommendations where there is silence, I think they are fairly unanimous, with the exception of using pulmonary embolism rule-out criteria, reason being some of the guideline writing committees were concerned about external validation or relevance to specific subgroups. For use of CTPA, again, for the most part, they're in agreement. Couple of points that caught my attention. One is that the American Society of Hematology guidelines actually consider VQ as a very good first step test in centers of a good experience, as opposed to most others that if they comment on it, they recommend CTPA. And the second piece that we will hopefully have time to discuss more is this last but not least final issue. Diagnostic approaches in pregnancy. These are one of the most vulnerable populations that we serve, and it's essentially lives of two people, and yet most of the guidelines are silent about it. So something that we can talk about more. And let's go back to what the imaging studies show.
Yeah, so the patient, due to the high pretest probability, we elected to go straight to CT-PA on the patient, and as we could see here, the patient has bilateral PE. Pretty high clot burden. In the CT, you could also see when we look at the RV to LV ratio, we see that it's about 1.9. So kind of already going into the, that there's some dysfunction and some into the RV as well. So we go to the next. So the clinical course, the patient, he continues to be hypotensive. So you can see here a map of less than 65, so systolics about 90 to 45. Troponin was, this is an old troponin, so it's not the high sensitivity, but it was negative at 0.05. Lactic acidosis, the patient, it was elevated at 1.95. So our questions to the expert is, what's the next step?
Excellent. Well, I want to first thank Dr. Moores for inviting us to participate and all of you for welcoming us. I do want to say my very first oral presentation at any scientific meeting was in a session that Dr. Moores was overseeing, and I must have looked terrified because she came up to me and said, "It'll be okay." and it was okay, and so I always remembered that kindness. I'm going to talk a little bit about risk stratification and how we approach Dr. Urrueta's patient. The current schema for thinking about patients with pulmonary embolism is to break them up according to clinical presentation, in particular hemodynamics, looking at biomarkers, in particular the troponin, and then imaging markers, as Francisco showed us, looking at the right ventricle. But there are a lot, as we look at this, if you take care of pulmonary embolism patients, you know that it's very hard for all of our patients to fit into just 4 categories. And some of the important things that are left out of, these are helpful schema, but they still leave things out, are patients who have respiratory predominant symptoms, where they may have respiratory failure, but they don't fit, their blood pressure is okay. Their troponin may be only mildly elevated, but they're very sick. In patients that we would traditionally categorize as high risk, there are patients, a wide spread of patients, some with 1 pressor hypotension, some with 3 pressor hypotension, some with refractory cardiogenic shock. How do we account for that heterogeneity? And then in intermediate risk patients, there are some patients that are in preclinical shock that we miss because we don't have a way to identify them. And so there are definitely gaps in our risk stratification. For Dr. Urrueta's patient, we have a patient who's hemodynamically stable, but they have an elevated troponin and they have evidence of right ventricular enlargement on the CT scan. So they would fall into what we would consider this intermediate high-risk PE population. When we looked critically at the guidelines for the article that has been mentioned, there are many different sets of recommendations, but not a lot of sort of homogeneity and not a lot of consensus. So most of the guidelines address, or at least half of them endorse, risk stratification as part of our job as clinicians taking care of pulmonary embolism. There's pretty good consensus about low-risk PE patient, but where there's a lot of heterogeneity is in the intermediate risk, or what we used to call submassive pulmonary embolism. There's also even heterogeneity in how to identify patients who aren't doing quite well with their pulmonary embolism. How do you define deterioration? That's not something that's well prescribed in the literature or in the guidelines. Pulmonary embolism response teams can play a very important role, and yet if you look at the guidelines, at least 3 of them don't make any strong recommendation about whether you should have a PERT and how that should be organized. 3 of them suggest them strongly, although again with limited evidence. So thinking about these risk stratification gaps, and I think Dr. Urrueta's patient, we kind of have a reasonably good sense of what we need to do for him. But in this case, when we look at the tools that we have at our sort of widespread disposal, we tend to use troponin and brain-type natriuretic peptide. They're readily available. One of the challenges is the specificity. Actually, Dr. Bikdeli has helped us to understand this. The specificity of high high-sensitivity troponins may be not as good as we thought. Most of the data come from conventional non-high-sensitivity assays. The high-sensitivity assays seem to identify more patients with a positive troponin, but not necessarily more patients with risk of an adverse outcome. There are lots of imaging tools. We have echo and we have CT measurement of the RV to LV diameter ratio, but these are one-time studies. They don't tell us where a patient is necessarily going, and that can be an important limitation. And the other thing has to do with risk scores. We use things like the simplified PESI score. There's a CPES score looking for almost like a shock index. But again, longitudinal evaluation of these over time really is lacking in the literature, and many patients still slip through the cracks when identified as being low risk and still deteriorate. So there's a lot of work we need to do to better understand and risk stratify patients. Dr. Moores and I are working on guidelines to see if we can come up with more precise ways of determining who's going to do poorly and who needs more advanced therapies. There's a real disconnect in one of the metrics that we've used, and I want to call this out. This is thrombus burden. In Dr. Uhueta's patient, there's a saddle pulmonary embolism with bulky thrombus in both main pulmonary arteries. But how important is that? If we look at data coming from one study, Furlan and colleagues, you can see that patients who had higher clot burden actually had better survival compared with the patients who had lower clot volume. And that's because we don't actually think that the proximal clot volume is the whole story. A lot of it depends on the patient's underlying cardiopulmonary status. We've all seen young patients with very bulky anatomical disease who do okay, and then elderly patients with a lot of comorbidities who maybe with a lobar pulmonary embolism or multiple lobar Ps aren't doing well. We've done some work with our pulmonary colleagues at Brigham and Women's Hospital looking at more distal measures of pulmonary perfusion using this type of a 3D reconstruction, and that really does seem to correlate with survival. If you do a 3D reconstruction of the pulmonary arteries both before and after different interventions, you can see actually a lot of dropout before with the initial diagnosis of the PE. And when patients have sort of this oligemia, which could be like you would see on a CT scan or a plain X-ray, a Westermarck sign, a focal oligemia, you can actually see that more clearly with this type of CT. That actually has implications for survival. And so we've got a lot of work to do when it comes to risk stratification. I think it works fairly well for Dr. Uhueta's patient, and we'll hear more about what was done. Thank you.
So just a recap when it comes to our patients. This is a 66-year-old patient, history of hyperlipidemia, diabetes, and obesity. Had recent surgery 3 to 4 months ago and recurrence in his left knee septic arthritis, which he had a total knee replacement 14 days ago. Now comes in with a saddle pulmonary embolism, hypotensive with a MAP less than 65, and on vasopressors as well. Troponin was negative, although he did have lactic acidosis. And we see in the imaging studies that he did have an RV that was enlarged compared to his LV at 1.9 was the ratio. So the question to the audience is, what would you recommend for treatment when it comes to it? Okay. All right, so we'll go forward. So,
All we are missing is ECMO.
Yeah.
I'm I'm going to ask our panel to comment on this, and then I'll also invite the audience to give your thoughts, perhaps defend what you voted for. But Dr. Piazza, looking at the way Dr. Huerta summarized this patient, would you still call the patient intermediate high risk? Has anything changed? Does it affect what you would do in this situation?
Yeah. Remind me, hemodynamics have stayed.
So he's hypotensive on.
He's become hypotensive. All right, so now he's high risk, so he's moved. And high-risk pulmonary embolism is something that, if we look at the guidelines, there's still some heterogeneity, and we saw that. But we would think about reperfusion if at all possible. And so I think looking at these options, it depends on the center that you're at. Some of them, I think at the time this patient was seen at our center, we were still doing quite a bit of surgical embolectomy. And this patient, remind me, was total knee post-op. So that's going to raise some issues with fibrinolysis and the risk of major hemorrhage. So I think that thinking about this patient, we're looking for some sort of method of reperfusion that's going to at least use a very low dose, if not avoid lytic completely.
Doctor.
Thank you so much. I agree with a lot of what, I guess I can speak also without the mic. I agree with a lot of what Dr. Piazza shared, with a couple of quick edifications. Completely agree that with this recent surgery, systemic fibrinolysis is going to be a major challenge, and the surgeons most likely would not be happy with it. The second piece that caught my attention, if my memory serves right, this patient is febrile. So besides the physiology of obstructive shock, I tend to think, could we have a septic plus a cardiopulmonary process going on, which may need more support. That's why I was looking for ECMO, either as backup or maybe as an add-on to other tools. But if we were to think, I think systemic anticoagulation is off the table as monotherapy, and most likely so is systemic fibrinolysis. Between the other tools, it depends on institutional comfort and how quickly you can mobilize resources, in my humble perspective.
So I might challenge just one point that you made. Dr. Bikdeli, and I agree with you, what's causing the shock, right? And if, in fact, it is sepsis and not obstructive shock from the PE, might you argue for just anticoagulation? Treat the sepsis, don't get too aggressive. Well, I don't know, what do you think?
I think that's a very elegant thought, and part of it also is all of us, when we go to the room and examine the patient, the feel of it, and like a couple of more data points, if we have time to have another hour or two of follow-up, also tells a lot. At least having pressors available, having central access, and letting the other stakeholders know of the patient so that if things go in the wrong direction, we can act quickly, but cannot agree more.
Yeah, so what Dr. Morris has raised is a really key point, and it's one of the places where the guidelines sort of fail us. What do you do when you have a patient that might have hemodynamic instability for more than one reason? Nowhere in the guidelines will you read about sort of how do you distinguish between the different types of shock and how do you manage these patients. They assume that the patient always has obstructive shock. The other thing is something that Dr. Bikdeli alluded to, which is the need for serial observation. That's also notably sort of missing in the guidelines, which is tools to assess patients over time, because that might give us some clues as to what type of shock they have. There are some advocates of using scoring systems like the NEWS score and looking at how that changes over time. Some of the randomized controlled trials for PE intervention that are ongoing right now use NEWS for serial evaluation. But again, absent from the guidelines, and really something that I think we need to start. I mean, we do that clinically, right? In the ICU, we don't make one decision based on that first admission set of vitals. We monitor patients. And I think that what we do naturally needs to come out in the guidelines too.
Yeah, I agree. And I think, one of the things that we struggle with is, as in the schema that Dr. Piazza showed you, you get to this, intermediate high risk, intermediate low risk, probably don't need to intervene aggressively with the low risk. There's a lot of debate about the high risk. But if you look at management schema that follow that, everyone says you need to worry about that patient, consider reperfusion. I don't know what to do with the word consider. Okay, I considered it. It doesn't help us. So what specifically, as we've been talking to, what does deterioration look like? And over what period of time? And when do we say we've watched long enough that they're not responding? Or even how do we define response to systemic anticoagulation? Are they actually getting better?
That's another key question. The guidelines say deterioration, but what are we supposed to do with a patient who hasn't gotten better after 48 hours or 24 hours of good quality anticoagulation? Isn't there a need for something there? We don't know.
And one more quick point, if I may, to chime in, agreeing with Dr. Morse and Dr. Piazza. Bedside echo can also tell us a lot, especially in this physiology where we are concerned about sepsis. If we see evidence of a very collapsible IVC, I tend to think of this case a little differently compared with when it's plump and not necessarily suggestive of systemic hypovolemia being a contributor to this hypotension.
Excellent. Okay, so again, we're hoping to have plenty of time for your thoughts and questions. I am going to address briefly the therapeutic options that we put in front of you. We discussed systemic thrombolysis, and if you look at the data, there is no clear mortality benefit for intermediate high-risk PE, but if the patients deteriorate, rescue reperfusion is successful, and that's why this definition and time frame is so important to us. We all know that if we give systemic thrombolysis, we have to balance that risk of bleeding, and particularly in unstable patients such as Dr. Huerta's. This may be someone that might have significant increased bleeding than you would see in another patient that isn't quite as ill. And despite the guidelines, systemic thrombolysis is very underutilized. That's another area we need to do work. I don't think, you might get a different answer from the three of us, but it's interesting. That has become sort of the gold standard, right? Every guideline says give systemic thrombolysis to high-risk patients. But if you think about that, that was based on a trial with 8 patients, right? We haven't gone back to study that question, and is it really the gold standard? I'm not so sure, but it is readily available, and if you don't have interventional capabilities, it certainly is something to consider in your higher risk patients. I don't think that's changed. Now, Dr. Piazza mentioned in his institution, they tend to go to surgical embolectomy, or they used to. I don't know if you still do.
Not as much.
Okay. I think about surgical embolectomy. I used to think that's done, right? That's old school. I'm wondering if it should be back new again. I've learned a lot from the cardiothoracic colleagues that are trained and comfortable with this procedure, and we're seeing a lot more data now on outcomes in surgical embolectomy, and you can see, based on all of these studies, that the mortality is actually much lower than what at least I learned on when I went through fellowship. And importantly, when you look at this mortality, these are patients that are the sickest, that have often already failed thrombolysis, because that's when we call the surgeons, right? So I think that if we could figure out, as Dr. Piazza said, this high-risk heterogeneous group who might benefit from embolectomy right up front, not after everything else has failed, that might be the ideal candidate. And in fact, when you look at the outcomes comparing thrombolysis and surgical embolectomy, you can see that patients do very well in the hands of a surgeon that is well trained to do these. So if we look at the guidelines, again, you can see there are some areas of consensus. And in fact, looking at systemic fibrinolysis, as I mentioned, as first line in patients who are high risk, who are in shock, everybody agrees on that. But I wonder if that isn't one that's going to start to show discrepancies, because we're starting to really critically evaluate where that recommendation came from. I think each time the guidelines, I know for the chest guidelines, each time we update those, we're looking for new evidence to change what we had. And there's no new evidence, so we haven't changed what we had. But I'm not sure that that's the right approach. And perhaps looking at real-world data until we have randomized would be helpful. You can see that for patients that have systemic fibrinolysis or the agreement as well is in patients who are stable, that they all say do not do this. Where you see some heterogeneity is in the use of catheter-directed therapies. So catheter-directed interventions, certainly a lot of growing interest in this. They're cool, they're fun. You know, I've never done one myself, but I've played with them. All guidelines do suggest the use, but with different levels of certainty and in different situations. So it's really hard to say the guidelines say I should do this intervention. And as best as I recall, none of them say which intervention. They just say catheter-directed. So we have a lot of options, right? We can use a thrombolysis catheter, we can use a suction thrombectomy, a mechanical thrombectomy, and there is no mention of whether we should use one or the other. So should we, right? A lot of the people in the room said that that's the approach they would have taken. And I think from the good side, we do have single-arm studies. We have several that show that catheter-directed interventions are effective in improving RV function in the short term, similar to what we looked at with thrombolysis. I think the bad side is that we don't have any randomized data, at least at this point. So in looking at comparing catheter-directed therapy with the other options that we have, so comparing it to anticoagulation alone, you see the more rapid recovery of the RV, more rapid symptom relief, particularly for some of those patients, especially the ones that are incredibly dyspneic, right? Or the ones that look at you and say, I can't move, I won't get out of this bed. Helping them more quickly, but they do come with increased costs. There is a risk of bleeding with catheter-directed therapy, but it is lower than thrombolysis, as you see on the comparison. Another advantage of some of our catheter-directed approaches are the fact that we have these different devices, and we can tailor that to the patient based on where the clot is and what the physiology is, and trying to decide what's going to be best approach for them. And then you see one of the biggest things, and this was very apparent in a session we had earlier in the week, is availability. We had many many providers in the audience saying, I'm in a community hospital. I don't have any of that. And guidelines are saying I should start thinking about that. What do I do when I can't access that? So hopefully we're going to have some answers, or at least better information. I think I'm a little too optimistic that, we're going to answer the question. And every time we answer the question, there's like 10 more questions. But there are multiple ongoing trials looking at both catheter-directed interventions with different devices, as well as half-dose TPA, which isn't something that I touched on. Currently, the guidelines really don't discussed half dose either. So but I think a lot of us may do this, right? So getting more data on that.
So the patient, we placed him on a heparin drip, and then due to the increase, he had increased vasopressor support during the presentation. Obviously, he came in hypotensive. Due to his recent surgery and multiple knee procedures that he had done most recently 14 days ago, we felt systemic thrombolysis was just too much of a high risk. So we elected a pulmonary embolectomy. And again, the patient, as you can see in the picture, he had everything went well. We were able to stabilize him, and he tolerated the procedure. The next day, we did place an IVC filter due to the anticoagulation that he was going to go home with, and then he will need to be followed up in our clinic, which he did to this day. And our question to the audience is if there's any comments or disagreements with the clinical course or the decisions made. So he was going to be, due to the, he wasn't going to be coming back for numbers of other procedures in the future as well for his left knee replacement. Ortho felt it was better to place an IVC filter. He had this wasn't his first go around with this knee replacement. He had other ones as well in the past. The last 6 months he had at least 2 to 3 procedures. So they felt there was some risk in continuing anticoagulation. Yeah. Yes.
Thank you guys for a great case. I noticed that your option was low molecular weight.
Yeah.
I frequently, when I have something like this, you mentioned that you placed them on a heparin drip almost to get that additional data. Is that something that you would advocate for?
Yeah, it's actually a really hot topic right now. Certainly within the guidelines discussions that we've been having that Lisa and I are privy to. Some more recent data show that a lot of PE response teams tend to gravitate towards unfractionated heparin, especially in intermediate and higher, because of this idea that if the patient's going to go for a procedure, we need something that we can turn on and off very quickly. Other data that come from pulmonary embolism response team experiences actually show that within the first 48 hours, very few of those patients actually achieve a therapeutic activated partial thromboplastin time, and very few actually do so consistently. And so there's a real call for low molecular weight heparin to be used because it's consistent and for most patients very bioavailable, and provided they don't have really impaired renal function, it's a good option. Most of the conventional trials right now that are looking at catheter-based therapies allow for low molecular weight heparin, and most of our operators, I think, are comfortable doing their procedures in someone who's received low molecular weight heparin. So I think there's a shift now to at least reconsider unfractionated heparin as that first reach for. And one thing I wanted to add separately that Lisa had mentioned about sort of the option of systemic fibrinolysis, perhaps not in this case, but in patients that get their care in a rural setting or a community setting. Actually, there are data that show that 40%, worldwide, 40% of patients with PE actually access their care through a rural center that may not have access to catheter-based or surgical embolectomy. And so having a safe lytic option is important.
I want to quickly follow up on it. And full disclosure, being a cardiologist, when we run into emergencies like severe acute PE, always reminds me of what we've been doing for ST segment elevation myocardial infarction. 25 years ago, a lot of patients didn't receive the treatment that they needed, or if they did, they received it with a lot of delay. It was too late. And unfortunately, so I think all of us have had at least a handful of cases, either en route from transfer from another hospital or other circumstances, they did not receive the treatment they needed. Epidemiological studies show less than 30% of people receive the aggressive treatment they need with severe PE. So I think that's hopefully a low-hanging fruit all of us can work together to improve. And the trickier situation is the one that Dr. Morris and Dr. Piazza elegantly showed. What do we really do with these intermediate risk patients? Hopefully the trials show what the best treatment for different subgroups are. But overall, again, if we look at epidemiology, the vast majority of them, unlike high-risk PE, do not die even if we treat merely with anticoagulation. So the question is what sort of other complications we're going to save with these very interesting tools.
So I appreciate the question on the IVC filter. I will, full disclosure, when Francisco sent me the case, I said, "You put a filter in?" Like, why? Not really understanding. I had to get some more context as to the bleeding risk for the patient, and there was concern, and I think we've all dealt with our surgical colleagues where they just are very uncomfortable with anticoagulation. So again, what do the guidelines say? They are consistent in the place where they recommend IVC filter, and that is in a patient with a contraindication to anticoagulation. So I think that's very reasonable in this patient. You can see beyond that, though, There's absolutely no agreement in the guidelines as to when else you might want to use a filter. And in talking to my colleagues in the field, I think it really varies widely, whether it's institutional or their anecdotal experience, whether they're in a CTEF center and have watched these patients go on and know they're going to need other things. It does vary. But you can see that the one area is the contraindication. The other area where there's somewhat agreement, or at least they don't say anything, but if they do, recurrent PE despite anticoagulation, that's another one that is difficult though, right? What actually is recurrence? Can you definitively say that this is a recurrence, or did they just not take their anticoagulant? Are they not responding to it? That was a bigger issue, I think, with vitamin K antagonists than the DOACs, but a lot of questions for us to answer around that.
So as stated, previously that patient continues to follow up to this day with our in our clinic vascular medicine. We did re-challenge him with anticoagulation, knowing with the orthopedic colleagues that it was okay to do so. The patient tolerated the medication well. There was no bleeding, and there was, again, no plan for further intervention when it comes to the left knee. So we were able to remove the filter, rather quickly when it comes to it. We had a repeat echocardiogram as well, because during the hospital course, he showed that he had RV dysfunction, not only from CT, but also from the echo. And the echo in clinic showed that there was some improvement to his RV function. And of course, compression stockings we recommended as well in the patient.
So
why?
there's another place where the guidelines don't always mesh up is in sort of the follow-up care. When do you do an echocardiogram? How do you follow patients for their recovery? What sort of, how do we identify patients that have a post-PE syndrome, or how do we monitor for chronic thromboembolic pulmonary hypertension? All really key questions, but all sort of vague areas of the guidelines.
And I won't spend a lot of time on this slide. This is just looking at the acute treatment. Again, you can see the consensus for therapeutic anticoagulation for all patients with acute PE unless they have a contraindication. And then there's some variance as to some comment on what type of agent, some do not. Some talk about the oral phase, and most of the newer, or I say actually all but one now, are stating that DOACs would be the first choice over a vitamin K antagonist for oral anticoagulation. So we talked about that, right? The patient comes back and returns at 3 months, and what do we need to discuss then? And one of the things that is becoming apparent is how many patients remain symptomatic after they've gotten those 3 or 6 months of anticoagulation. And of course, they don't all have CTEF. But we're recognizing that there are other entities that fall into persistent pulmonary vascular disease that aren't CTEF. So whether that's CTED or CTEV, or just dyspnea without pulmonary vascular disease, we're starting to see some algorithms to help us approach those patients. So we do want them to come back. I think that's another thing that PERT teams have helped with, is ensuring these patients get connected and follow up and don't just get sent out with anticoagulants and get lost. So reevaluation at 3 months is recommended by the European Society of Cardiology and PERT. The CHEST guidelines and others don't really address follow-up care. It's not that they would disagree with that, but they don't address it. And then in those patients who remain symptomatic, getting an echo, as was done here, although he wasn't necessarily symptomatic, but still getting a follow-up echo or VQ scan, depending on what your concerns are. As I said, there's growing interest in what's called the search algorithm to kind of methodically go through patients that remain symptomatic. So 3 months. The other thing you need to discuss with the patient is what do we do now? Is 3 months sufficient? So thinking in every patient, what is their risk of recurrence? And what is their risk of bleeding on continued anticoagulation? And that's another area that we still need to do some work in. I think we're getting better at it, but we're starting to recognize that just Not everybody needs to stay on extended anticoagulation. However, with the DOACs now and reduced dose, I think there's a shift again to say, well, it's so safe, I'm just going to keep everybody. And I don't know that that's the right answer either. I think we really need to discuss with the patient and go through some shared decision-making. What is their risk of recurrence, and what are we trying to prevent? The other things, as Dr. Piazza said, is the guidelines don't address lifestyle modifications. Such an easy thing to do. Talk to them about smoking cessation. This patient, has obesity, talking about weight loss strategies, going over with them what they can do. Some of them really don't know, like, can I go back to work? Can I go back to my previous physical activity? And so there's a lot of things that, from a patient-centric point of view, we are silent in our guidelines, and we need to do a better job there. And in fact, we've sort of laid out some research priorities based on all of the things that we're finding when we compare these guidelines. And I'm just going to leave this slide up because I think it's a nice final comparison of the guidelines that we chose to highlight. And you can see that there are areas where there's agreement in less than 50% of them. And that would be lifestyle. And that's predominantly, again, as I said, because there's absent guidance. But also reduced dose of systemic fibrinolysis. Very little agreement there. You can see there's some agreement on many of the topics we discussed, and then 100% are at the bottom of our pyramid here, and we discussed most of those. So we want to open things up to the audience and see if there are additional questions that you may have concerning anything that we talked about. Yes, sir.
So for the rest of the audience, the question is whether or not presence of coexisting DVT makes a change in the recommendations for therapeutic interventions and for other procedures. I'll share my take at risk of embarrassing myself. So I think there is data for the intermediate risk category that presence of proximal coexisting DVT increases the risk, meaning it's not formally in the risk stratification tools, but it's one of those 50 additional variables that we look at, and it increases the risk. That being said, for high-risk PE, I'm yet unaware of data to support additional interventions for it. Of course, if you have a DVT, something to keep in mind, the one thing is not to massage that leg. There are case reports of those embolizing. Outside of that, I would personally continue standard of care for the PE, be it aggressive treatment or anticoagulation, depending on the situation.
Yeah, I mean, the data from some of the trials looking at aggressive therapy for DVT have been a bit disappointing, raising the risk of bleeding without necessarily reducing the risk of post-thrombotic syndrome. And so it's not really standard. And I think most of the care would shift to focusing on a significant PE and sort of putting the DVT on the back burner.
I think I saw you next.
Thank you so much for this fascinating conversation. I have two questions that I would like for you to address. One of them is, how do you personally approach a delayed diagnosis of PE? And specifically, the example is if the patient is transferred from another institution, is hypotensive, and is discovered to have a PE, would you use the current standards and the guidelines as such? And the second question really pertains to the follow-up, but 3 months or 6 months. As of now, we feel that repeating an echocardiogram or potentially CT is helpful for folks who have symptoms, but what are those symptoms from? And where does pulmonary function test and 6-minute walk test play into that?
Okay, so we have two questions. The first is what to do in a patient with a delayed diagnosis of acute PE, particularly someone that may have been transferred from an outside hospital without that diagnosis, and does it change your approach? And the second one gets to symptoms after. I'll address that one. Let me ask Dr. Piazza? Or-
So this is another place where guidelines don't really step in and provide suggestions. I think in the absence of specific suggestions for patients who've had a delayed diagnosis, you default to the upfront recommendations. If you believe that the patient's deterioration is related to the PE, then you would proceed in a similar fashion. The only caveat being if the symptoms, if it's really delayed and the symptoms are longer than 14 days, or you think that you don't have a good handle of when they really started, and then there's been this additional delay of someone sitting at an outside hospital without the diagnosis, that may impact the success of some of the advanced therapies. And so if a patient's really delayed in getting that diagnosis, actually, even with surgical embolectomy, surgeons get very upset if they go in planning for a surgical embolectomy and they find something that requires pulmonary thromboendarterectomy. That's a good way to make enemies in your CT surgery service. And we've made that mistake. So it really gets challenging. And in some cases, you may support them sort of hemodynamically and sort of pulmonary support with anticoagulation, and then try to figure out what's acute and what's chronic.
Yeah, and in terms of the question about, evaluating patients with persistent symptoms, that's one of the nice things with the search algorithm is it really does right up front address that, are the symptoms related to the PE? Or is there a comorbidity, something else going on? And so pulmonary function tests would be recommended right up front. Potentially other imaging that is not focusing on pulmonary vascular disease if you get the sense that there's additional diagnoses. But those need to be ruled out first. And then you say, okay, persistent symptoms, got anticoagulation, now what? And then there's sort of a stepwise approach of looking at cardiopulmonary exercise testing, VQ and echo. And then if all of that fails, going to an invasive cardiopulmonary exercise, looking at exercise hemodynamics and dead space. And so it kind of steps up as you go along. Probably have time for one more in the back there.
One quick update, if I may. The paper is, by the way, now available online in Jack J. This is the QR code. Thank you.
So when do you use echo with bubble to kind of stratify high-risk patient where you think some intervention? And what do you worry about paradoxical like?
So the question is, when would you use echo with bubble, looking for the risk of paradoxical emboli, particularly as you're thinking about your invasive procedures? I'm interested in what my cardiologist friends would say. I don't ever use an echo bubble routinely in looking at patients with PE. I do think there are times on imaging where you see, particularly if you see clot in transit, where you might get much more aggressive with your echo, but I don't know that we would use bubble, right? I don't know, Greg.
Not up front. Even if they have evidence of PE and concomitant paradoxical embolism, you're anticoagulating anyways. So establishing the diagnosis of a PFO doesn't really change anything, with one caveat: if you're going for surgical embolectomy, then they'll close the PFO at that time.
Sir.
So back to the stratification, a lot of emphasis has been on the intermediate risk. This gentleman, in this case, on two pressure shots, we're talking about.
High risk.
High risk, yeah.
So you showed us how clean that embolus surgery removed that saved his life. You talked about the propagation of the catheter-directed intervention that is not available in every center. Short of the surgical or the PCI, a guy, if you sort out the fever part, with two pressors on board, what's the holdup of thrombolytic?
There shouldn't be a holdup on thrombolysis if that's the option that you have and you have a high-risk hemodynamically unstable patient. In this particular patient, it was really the risk of bleeding in the recent orthopedic surgery, so that would put a lot of pause. Some places might try to use a lower dose of systemic thrombolysis and see if they could get away with that. There are obviously catheter-directed lysis, which are felt to be lower risk of bleeding, but you may not have access to that either. But if that is all you have, it should absolutely be in your decision-making. It's just, in this case, probably not a good idea. But.
Agreed. I think in a patient that would have such a risk of major bleeding, if you don't have access to a catheter-based or surgical embolectomy approach, then you would support them on anticoagulation rather than risk giving them a major hemorrhage and hypovolemic shock on top of their PE.
Yeah.
Yeah, we've seen it. Yep.
Yep. Well, and I think it's why Dr. Bikdeli said, really, nobody said ECMO? Now, again, you may not have access to ECMO either, right? But I think it brings up the point of having a contingency plan and having large bore access and being ready to support these patients because they can crump very quickly. Yeah. All right, well, I want to thank everyone very much for your attention and your participation. Please remember to rate on the app.